My name is Damir Benkotic and I am a Regional Scientific Support Manager for Neuroscience and Urology in Allergan. I welcome you here for the workshop about the treatment of spasticity with botulinum toxin. We were mostly, well, as you know, the approved indication for the time being is a hand and wrist. However, we are very happy and lucky that we are announced that the approval for the lower limb spasticity is on the way and is expected, if everything goes well, by the end of the year. So there is as well the program, as you know probably, that there is approved program for treatment of spasticity, which will be explained to you later on, which is very important for the proper use and application of Botox in the spasticity. With this, I give a word to the hosts.
Welcome, Professor in Katowice. Our interest, your guest and lecturer, excellent lecture about spasticity. We hope to continue our education today. We prepare 9 patients.
Okay, you're making me work hard.
Yes.
Why don't you come through here? I see a middle-aged lady, attractive middle-aged lady, who has a right-sided weakness. She has some clawing of her toes, and she has some flexion of her arm, and she doesn't walk without support of her daughter. And so therefore, she's had 3 strokes. The last one was December 2009, so nearly 5 years. And as you can see, she's had a right hemiparesis. She's got difficulty with dexterity, you know about it, and difficulty with walking. What is your, if someone could translate, what is your biggest problem? Her big toe, great toe, comes up. But when you saw her standing, you saw the big toe come down. She doesn't claw like that. She claws like that. And that muscle comes from that movement comes from the flexor hallucis brevis muscle. Stimulus there. But I think that's certainly where it should be. Okay, I'm going to stop this. She's getting a little distressed. And 20 units into there. I pull back on the syringe. It is better not to spray alcohol on the arm, except for the foot, because it takes 20 minutes for the bacteria to be neutralized. And all you do when you spray the skin and then put a needle in is actually stir up the bacteria, and you advance on the fluid, you advance the bacteria into the skin rather than on top of it. The foot is different, because the foot has got a lot of, you scrape the surface of the skin rather than the bacteria. But it's better not to do this here.
Lepiej jest w ten sposób.
And a cool like this. Good. So, and one of the problems is he's very strong. This is a problem in terms of the hand. Gosh, that's just tight, isn't it? Can you break that? Wow. And that, I presume, does that finger bend like that? No. It's always straight, is it? So one would try to keep that uninjected, if you like. But certainly the other finger.
But it is straight, but in the metacarpal joint is flexed, as I...
Oh, right, okay, when you
it's
assume, yes. If we have someone who has no function in the hand, then we have to think again about what we are trying to achieve. The reasons, I remember the lecture yesterday, there are 5 reasons to treat patients for spasticity. One is to improve function where it is possible to do so. Second is to relieve symptoms, pain, sweating of the palm, hygiene, care, putting the hand in a splinter if they're fighting the splinter. The third is to relieve posture and to allow, for instance, the chap with his elbow coming up like this. The fourth reason is to relieve the burden of care and to get the hand through a sleeve and help with dressing and hygiene. And then the fifth reason is to prevent complications forming as well. 25 units times 2, 25 into, and again I'll move the needle around. Now, this Diana is exactly the kind of patient, if she was in my hospital for an assessment, I would give her a little bit of midazolam to sedate her, sedate her muscles and sedate her, and I would see how contracted this is. Because if this is all spasticity, it will come out completely flat. And she would be relaxed, and the muscles, you could see exactly what is going on. I would give her about 4 milligrams of intravenous midazolam, and it would, over 15 minutes or so, make her a little bit sleepy, and you could would relax the muscles. And this is where you have tiny doses of baclofen into the spine, and you have this little pump that sits in the tummy, just under the wall of the tummy, and has a catheter, the little tube that goes round into the spine, and it will reduce all this and still allow you to stand, because you can adjust the dose by 1 microgram at a time if necessary. Well, she's not. Gabapentin I tend to use for sensory disturbance more than just an antispastic disturbance. So if you have someone who has, for instance, cortical dysesthesia producing spasms, then fine, use gabapentin. But I think in Diana's case, I think is purely as a result of the increased sensory input from the fracture. And you could do, but again, they sedate you. If she was sedated on baclofen, she probably would be sedated on gabapentin as well. We don't want a sedated person. She's too bright and intelligent for that. Okay, she's artificial. Well, we have therefore a system of actually having a number of people with individual goals for treatment, and it's their goals, not our goals. But we have put a level of performance against that. But we can put a score on that. And while there is weakness in this scale, because we are artificially creating levels for these goals, it is actually very valuable for your service. Because my payers asked me in April 2013, my payers asked me, what did you do last year? How good are you? And I was able to say that 83% of our patients achieved their goal for treatment. In other words, 83% achieved 0, +1, or +2. And 92% of patients achieved improved, i.e. achieved -1 or more. And that's better information than our cardiologists could give, or our oncologists, or our surgeons. All they could say is, we saw this number of people, we treated this number of people, this number of people died, and this number of people walked out of hospital. We were able to say all that, plus the fact that we have a good team, and we are achieving the goals for treatment. And that's very important when you want somebody to invest in your service. We're good, we're good, and we can show that we're good. And I think this is a good way of doing it. And learning about the goal attainment scale and practicing it, and you're more than welcome to come and see our team doing it. The team gets to be very good, very quickly, at achieving realistic goals for treatment that are achievable.